Good morning, everyone. This morning, I will give a new lecture regarding to cervical and lumbar degeneration. My name is Wu Junsong, Department of Orthopedic Surgery, the first affiliated hospital, Zhejiang University. Now, this page, we can see the spine's area divided to 5 areas. This is cervical spine, thoracic spine, lumbar spine, sacral, and coccyx. Enlarging the lumbar spines, we can see the transverse process, spinous process, nerve root, and chorda equina. The motion segment. The function unit of the spines comprised for 4 components: 2 ancient vertebrae, intervertebral disc, ligament, and 2 facet joints and capsules. The structure of lumbar disc comprised by nucleus pulmosus and annulus fibrosus. The phase of spinal degeneration comprised by 3 phases. 1 phase is dysfunctions. The phase 2, instability. Phase 3, stabilization. Phase 1, dysfunctions. Between 15 and 45 years old, characterized by internal vertebral disc fiber ring, circumferential tear, and ratio tear, synovitis or facet joints. Phase 2, instability. 54 and 70 years old, characterized by internal rupture of disc. And the second, progressive absorption, facet degeneration, accompanied with capsular laxity, subluxation, destruction with joint surface. Phase 3 is stabilizations, above, or we can say beyond 60 years old, enlarged articular processes, one-level stenosis, and multi-level spondylosis and stenosis. This table we can see the 3 phases: dysfunction, instability, and stabilizations. Risk factors, interactions, comprise facet joints, intervertebral disc, and the pathologic result. This is the nutrition of disc. The largest avasta structure, diffused blood supplies. The damage to the blood supplies lead to degradation of the disc. Cervical degeneration. The cervical spondylosis refers to the cervical intervertebral disc degenerations, secondary change and stimulations of rest adjacent the spinal cord, nerve, blood vessels, etc. The function unit of cervical spine, and we can see the disc, Lusca joint, and the facet joints. Etiologic factor and pathology. Genetic influence is the most important, and the second is the decreases of proteoglycan and water component in disc, hypermobility of facet joints and relative instability, appearance, osteophytes and osteoplasia of vertebra and facets. Special, we need nerves. The ligament flava, hypertrophy, and the posterior longitudinal ligament. Genetic influence is the most important. Now, we can see the decreases of protein glycan and water component in disc. Radiolins, the loss of water and proteoglycans. Little change in collagen content. The third, molecular changes. The prolonged mechanic loading caused apoptosis in disc cells. Interleukin-1 also decreased matrix production and increased matrix breakdowns. All this lead to height loss and disc prolapse. This is the dynamic X-ray. Now we can see the foramens. Etiologic fact and pathologies. We can see the ligament, longitudinal ligament, prolapses, abreast the dural sac. Clinical presentations, including abnormal sense and mild anemia, pain, numbness, dyslexia, hyresia, and tongue lonesia, weakness, and extremities. Increased activity of Turner reflex, positive sign of Hoffman and Babinski's. Classification divided to 4 types. The first, root type, spinal cord type, vertebral artery type, sympathetic type. Cervical radiculopathy. Now we can see neck pain, medial scapular pain, shoulder pain, numbness in the fingers, and motor weakness. Hidden test proteins, sporting site positive. In these X-rays, we can see the prolapsed disc, abreast the dural sac, hidden tests positive, sporting site positive. Segmental distributions of sensory of cervical vertebrae. Different nerve root with different area. Now in this table, we can see the cervical 5 to cervical 8 nerve root compression and associated signs, including sense deficit, motor weakness, and reflex change. Cervical spondylotic myelopathy, abbreviated CSM. The pain is poorly localized and aching in nature. Occasionally sharp pain and generalized tingling may be described with neck extension, associated with generalized feeling of weakness in lower extremity and a feeling of instability. X-ray. We can see the cervical lordosis, disc narrowing, disc vacuum size, and cross balls and traction spurs. CT scans. Cervical intervertebral disc herniation, the prolapsed discs, abreast the dural sac and the nerve root. And also we can see the calcification of ligament, including yellow ligament. Now, at last, lead to the compression of spinal cord. MRIs also can the prolapsed discs abreast the dural sac. T2 weighted images since high signal of cerebral spinal fluid interrupted high signal area appeared in the spinal cord. Myelography, we can see the disc abreast the dural sac. Diagnosis, differential diagnosis, lateral sclerosis of spinal cord, muscle weakness without sensory disturbance, tumor in cervical part, the shoulder and upper extremity, arthritis. Treatment: muscle function exercise, non-surgery, fixation of cervical spine, traction. This is the traction, the cervical spine fixation, drug and injections. Now, this is the nerve block injections. Use the mispread nisolone, interrupt the conductor of nerve. Indications for operative treat very important, including three steps. One, the failure of non-operative pain management, increasing neurologic deficit, cervical myelopathy that will predictable progress. Surgeries: removal posterolateral herniation by posterior approach, post-cervical foraminotomies, anterior approach to cervical disc. And the third method, microsurgery anterior cervical foraminotomy. Minimally invasive surgeries. By the anterior method, we insect the prolapse disc. Endoscopic surgeries. The patient lies prone on the bed. Now we can see the nerve root. Posterior cervical fusion with the lateral mass plate fixate the adjacent vertebrae. Laminectomies resect the lamina, enlarge the vertebral canal. Fixations with the lateral mass plate fixes the adjacent vertebrae. Anterior cervical decompressions and fusions use the anterior plate fix the adjacent vertebrae. The position for operations: the patient lies supine at the edge of stereocleidomastoid. We can expose the vertebrae. This is also. Now we can see the case presentation. 54 years old females. We can see the prolapse discs abreast the dural sac. Post operations, we incise the prolapsed discs with the anterior plate fix the vertebrae. Cervical stenosis. Cervical stenosis is the narrowing of the spinal canal in the neck area and up part of the spine. It can be congenital and or acquired. The narrowing places pressure on the spinal cord and cause the symptoms. Etiological factor and pathology. Achondroplasia is the most important. Degeneration, disc, and facet joints. Hyperosteogenesis, hypertrophies of ligament flava and posterior longitudinal ligament. Hyperplasia of scar. Clinical presentations typically found in the individuals over the age of 15 years old, very like spinal cord type and cervical spondylosis, abnormal sense, and myodynamia, increased action of tender reflex. Positive side of Hoffman and Babinski. This is the type of cervical stenosis, including anatomic, pathological, and acquired. Diagnosis. Non-operative treatment, anti-inflammatory medications. For example, Celebrex, cervical collar or neck brace, physical therapy. Surgery treatment, including the compressive laminectomies, posterior lamiplasties, and foraminotomies, spinal fusion. Lumbar degeneration. Degenerative disc disease, abbreviated DDD, including internal disc disruptions, IDD, lumbar disc herniation, lumbar stenosis, lumbar spondylolisthesis. Degenerative disc disease changes including disc loss, height and volume, compressive loss transfer away from the nucleus to the margins, sclerosis of end plate, reduced disc nutrition, facet joints wear away cartilage, begin to override. Motion segment becomes hypermobile. Osteophytes develop to attempt to stabilize motion segment. Osteophytes may be encroach on neural structure. Spinal stenosis, narrowing of the spinal canal and or lateral foramen through which nerve travel. 3 types. Central stenosis, lateral recess stenosis, and foraminal stenosis. Herniated discs. In this page, we can see the herniated disc, ruptured disc, very common, pathologic, especially in lumbar 4 and lumbar 5, common locations, thought to be the culmination of acute traumatic events to the disc. Definition of lumbar disc herniation. Ruptured discs are among the most common and painful of all back ailments. The condition occurs when the outer cover of the disc is torn and the soft inner tissue extrudes. The extrusion often puts pressure on the spinal nerves, cause back and leg pain, which can be severe. Epidemiology, risk factors. Most factors affect the development of back pains: smoking, prolonged daily driving, lifting of heavy objects. It's more common in males than females and has a maximal incidence in the 3rd and 4th decades of life. Herniated disc. 4 degrees. Nucleus herniation, disc protrusion, nucleus extrusions, and sequestered nucleus. Clinical presentations: low back pain, radicular pain, called equina seizures. Clinical presentations: sciatic is the pain along the course of the sciatic nerve. The classic symptoms is the low back pain. It may be associated with neurologic signs such as motor and sensory loss, and occasionally bladder involvement. The level of lumbar. The most common level of between lumbar 4 and lumbar 5. Lumbar 5 and lumbar sacral ones. and sacral ones. For these reasons, reticular symptoms almost always refers to symptoms below the level of the knee in lumbar 5 or sacral 1 diaptoma. Leg symptoms can vary from numbness to dysphagia to true pains. The herniation of lumbar 4 and lumbar 5 disc can compress on the sacral 5. The lumbosacral disc causes compression of the sacral 1 nerve root. Physical examinations. The postures. Often there is a functional scoliosis. Range of motion. The lumbar spine may be limited due to the parietal muscle, spasm, or guardings. Forward flexions can increase the symptoms of sciatic. Palpation may show the tenderness in the sciatic notch due to the irritation of the nerve. Focal signs. Focal signs are dependent on the distribution of the affected nerve root. Physical examinations. Straight leg raising is a common test. Contralaterally positive straight leg raising and femoral stretch. Meticulous neurologic examination is necessary to detect the motor weakness, sensory changes, and deep tendon reflex asymmetry. This is a LASIK size. The most notable of this is the LASIK size. Or we can see straight leg raising test. Raise the low leg. Raise the low leg. Will irritate the sciatic. This is a Fabertrick test. Also, we can see the force size test in order to diminish the hip joint disease. X-rays is very limited value, but its most important value is the rule out the bony disorders of the lumbar spine, tuberculosis and tumor. Special radiographic studies, myelography, in order to show the compression and displacement of neural element. Discographies, in order to evaluate the patency of disc. The dialysis out of nucleus means incompetent disc. Injection produces pain. Means disc is the source of pain. CT scans in order to detect bony tissue pathologies. The CT scans, we can see the prolapse discs, abreast, the nerve root, and the dural sac. MRIs, in order to detect soft tissue pathologies. This is MRI. Now we can see the prolapse disc, abreast, the dural sac. Actual views, we can also see the prolapse disc. This value is to assess nerve root compression. Bone scans detect inflammation, infection, and tumor. Dark area means increased activity. Lateral protrusion of lumbar 4 to lumbar 5 disc. It may cause lumbar 5 root pressure with pain radiation down the leg to the dorsum of the foot. Protrusion of lumbar 4 to lumbar 5 discs with the weakness of dorsiflexion, particularly of the foot and the toes. Protrusion of lumbar 4, lumbar 5 discs. Protrusion at the lumbar 4, lumbar 5 level will thus compress the lumbar 5 root, while the protrusions at the lumbar 5 to sacral 1 level will compress sacral 1 root. Central protrusion of the lower lumbar discs. It can press on the cauda equina, lead to the urinary retention. One examination, there is a usual perianal numbness and patulous illness. Emergency decompression is essential to avoid permanent damage to sphincter innervation. Central disc protrusions. We can see the central disc abreast the thoracic. This is the central type. Urgent surgery, decompression of the cauda equina. Side central type abreast the nerve root. This is also the side central type. Side lateral types. Now we see the prolapse disc, side lateral. This is also the side lateral. Extreme lateral type. Symptom of the size. There is often associated spasm of the spinal muscles with the tenderness of the lower lumbar spine on the side of lesion. The muscle spasm may produce a scoliosis, limitation of lateral flexion of the lumbar spine to the same side will be the most marked with the protrusion lateral to the nerve root. The limitations of the lateral flexion of lumbar spine to the same side will be most marked of the protrusion lateral to the nerve root, with the limitation with the lateral flexion to the opposite will be the most marked with the protrusion medial to the nerve root. The differential diagnosis. Various causes of the low back pains need to different. The cause of localized nerve root pressure. This includes secondary tumor and multiple myeloma. Fractures and infections also cause nerve root of the spinal cord compression. Treatment. Not all patients need surgeries. Often start with the consultative, non-operative care. Patients with cauda equina surgery need surgery attentions. Common surgery procedure include laminectomies, discectomies, microdiscectomy, endoscopic discectomy, ablation procedure. Non-operative care, bed rest and sports tractions, lumbar corsets, heat therapies, exercises. Indication for operations. This is very important. No improvement in the symptoms and size after 6 weeks rest. An increase in the neurologic deficit. Blood and bowel involvement, suggesting a cauda equina seizure. Intractable pains. The 4 steps. Lumbar decoctoma. In the case of lambodectomas, the prime objective is to decompress the affected nerve root. The compressed nerve root must be left fully decompressed and fully mobile. This is discoctoma. Now, resect the pulposus. This is the lambodisc replacement. This is the radio frequencies, abbreviated RFs. Use the hypothermia, resolve the pulposus. Microendoscopic decoctoma, abbreviated MED. Use the tunnel technique. Resect the prolapse disc. Spinal stenosis. Spinal stenosis is congenital. In others, is secondary to the hypertrophy of the body element of the lumbar canals. Ligamental hypertrophy of disc degeneration. The stenosis may affect the central canals, lateral recesses, and the intervertebral foramen and the nerve root canal. X-rays be of limited values. CT is the investigation of choice. MRI is at least equal to the evaluating the various form of the spinal stenosis. Lumbospinal stenosis. Back pain almost always present. Buttock leg pain common. Neurogenic claudication increases with walking and standings. Usually cause back and leg pain. Relief with flexion forward. This is the stenosis of the vertebral canals. Treatment: conservative stringing swimming extensions, epidural steroid injections. Severe stenosis for surgeries, including central surgeries, laminectomies with medial fasciotomies may be enough. Stenosis in the lateral recess and the lateral foramen may require laminectomies, fasciotomies, and foraminotomy. This is the laminectomies. This is fenestration. This is entire lamina removal. Degenerative spondylolisthesis most commonly occurs at lumbar 4 to lumbar 5, result from the degenerative changes in fascias. May have a rotary subluxation and lateral listhesis. Lumbar 5 nerve root commonly affected. Low back pains and or leg pains are the common typical symptoms. Patients often complain of sciatic pain. X-rays, we can see the lumbar 4 and the lumbar 5 spondylolisthesis. The sleeper vertebral bodies. Degenerative spondylolisthesis diagnosis by spinal specialist through 3-step process, including medical histories, physical examination, and diagnostic tests. Unlike ischemic spondylolisthesis, the degree of the degenerative spondylolisthesis is typically graded always grade 1 or grade 2. In many cases of degenerative spondylolisthesis, the degenerated facet joints turn to increases in size, enlarged facet joints then encroach up the spinal canal, causing lumbar spine stenosis. Degenerative spondylolisthesis treatment. Non-surgery treatment including pain medications, brace. This is brace. Surgeries. Surgery for degenerative spondylolisthesis is rarely needed. Very important, rarely needed. Surgery is also indicated if the patient is experience progressive neurologic damage. The goals of surgeries are to realign the affected segments of the spines to elevate pressure on the nerve and provide stable to the area. Surgery for degenerations, spondylolisthesis usually include two parts: decompressions, spine fusions with pedicle screw instrumentation. Spondylolisthesis. Now we use the cage to fuse the two ancient segments. Now, next lecture, I will give you the spinal cord injuries. That's all. Thank you.